A lot of people think hair loss has only two options. Option 1, accept it. Option 2, get a hair transplant. But in real life, there is a very important middle zone. And that middle zone is medical treatment. Finasteride, dutasteride, minoxidil, microneedling, blood tests, scalp care, sometimes PRP or other supportive treatments. The real question is not, does hair loss treatment work? The better question is, which part of the hair loss problem are you actually treating? Because hair loss is not just one problem. It is usually a combination of hormone sensitivity, miniaturized follicles, inflammation, poor scalp environment, and sometimes nutritional or medical factors. So today, let's talk about how you can build a realistic hair loss treatment plan before jumping straight into surgery. And also when a hair transplant actually makes sense. The biggest mistake is treating every hair loss case the same way. Someone sees thinning hair. They buy minoxidil. They use it for 1 month. Then they say it didn't work. But 1 month is almost nothing in hair biology. Hair grows slowly. Hair cycles are slow. And damaged follicles do not suddenly become thick, strong hairs in a few weeks. In many patients, you need at least 6 months to see meaningful early changes. Often, 12 months is a better point to judge. And in some cases, the best improvement may continue over 18 to 24 months. So if you started treatment 4 weeks ago and you are checking the mirror every morning with panic, please breathe. Your follicles are not Amazon Prime. They do not deliver in 2 days. Now, let's make this simple. A good hair loss plan usually has different layers. I call this the treatment stack. Not because it sounds cool, although it does, but because each treatment has a different job. First, we have the DHT blocker. This is where finasteride or dutasteride comes in. DHT is one of the major hormones involved in male pattern hair loss. In genetically sensitive follicles, DHT slowly miniaturizes the hair. As the hair becomes thinner, shorter, weaker, and eventually less visible. Finasteride helps reduce DHT activity by blocking 5-alpha reductase. Dutasteride is generally stronger because it blocks both type 1 and type 2 5-alpha reductase. But stronger does not always mean better for every patient. The right choice depends on your age, degree of hair loss, side effect concerns, medical history, and treatment goal. Second, we have the growth stimulator. This is minoxidil. Minoxidil does not mainly treat the DHT problem. Instead, it helps stimulate follicles, prolong the growth phase, and improve the chance of thicker hair growth in responsive patients. This is why many patients do better when they combine a DHT blocker with minoxidil. One treatment protects the follicle, the other pushes growth. That combination can be powerful. Then we have scalp stimulation. This is where microneedling comes in. Microneedling creates controlled micro-injury in the scalp. That may help stimulate wound healing signals and may improve response to topical treatments like minoxidil in selected patients. But here is the important part. Microneedling is not just stab your scalp and hope for the best. Depth matters. Frequency matters. Clean technique matters. And your scalp condition matters. If you have active dermatitis, infection, severe irritation, or you are using strong topical medications, doing aggressive microneedling at home can create problems. So yes, microneedling can be useful, but it should be done carefully, not like a medieval punishment for your scalp. Now, let's talk about hair transplant. Some online videos make it sound like hair transplant is always bad. That is not true. A good hair transplant can be life-changing, but it is not magic. A transplant moves hair from the donor area to the thinning area. It does not stop your native hair from continuing to miniaturize. So if your surrounding hair is still actively thinning and you do a transplant without stabilizing the hair loss, the result can look good at first, then strange later. Because the transplanted hairs may remain, but the native hairs around them may keep disappearing. That is when people start seeing gaps, unnatural density, or a hairline that no longer matches the rest of the scalp. So the best approach is often this. Medical treatment first to stabilize, transplant later to rebuild shape, density, and hairline design. Medication is the foundation. Surgery is the architecture. You need both in the right patient. Here is the timeline I usually want patients to understand. At 1 month, it is too early. At 3 months, you may notice shedding, less shedding, or very early baby hairs. At 6 months, some patients begin to see visible improvement. At 12 months, you can judge the treatment much more fairly. At 18 to 24 months, many patients are closer to their maximum medical result. And after that, you maintain. Because androgenetic alopecia is not usually cured, it is managed. Like fitness, you do not go to the gym for 3 months, build muscle, quit forever, and expect the result to stay. Hair is similar. Consistency wins. So, can you regrow hair without a hair transplant? Sometimes, yes. Especially if the follicles are miniaturized but still alive. But if the area is completely bald and smooth for a long time, medication alone may not bring back enough density. That is where hair transplant becomes important. The key is not choosing medication or surgery. The key is choosing the right order. First, diagnose the type of hair loss. Second, stabilize the condition. Third, build a treatment stack that matches the cause. And only then decide whether surgery is necessary. Because the best hair transplant result often starts before the surgery. It starts with protecting the hair you still have. If you're considering a hair transplant, do not ask only how many grafts do I need. Ask this first. Is my hair loss stable enough to design a result that will still look natural years from now? That question can save you time, money, and regret. I'm Dr. Ko, hair transplant surgeon in Korea, and I'll see you in the next video.